Hello, my name is Dr. Hamid Nazir. I'm the Medical Director, the Department of Interventional Radiology at OSF Little Company of Mary Medical Center in Evergreen Park, Illinois. Today I just want to have a candid conversation on utilizing angio-CT for complex IR interventional oncology interventions and how it can solve everyday workflow issues. Let's just jump right into the cases. Pretty straightforward case here. We have a 58-year-old male with a history of hypertension, diabetes, and metastatic colorectal cancer to liver. Prior distal colon resection with treatment with FOLFOX regimen. Patient initially responded very well. On a 12-month follow-up PET scan, there was evidence of progression of disease, new solitary metastases within hepatic segment 7, kind of posterior upper right hepatic lobe. IR was consulted for additional treatment options. Patient was seen in clinic. Very good performance status. ECOG 0 was deemed a good candidate for possible radioembolization. We would try to take a segmental approach. Patient was scheduled for Y90 mapping in our angio-CT room in Alphenix 1, which we've had for a couple of years now. Thing's amazing. Love it. This was our preoperative cases, preoperative imaging showing hypermetabolic metastases within the posterior upper right hepatic lobe. No other lesions were identified. This is the pre-procedural CT demonstrating a vague area of the metastases within that hepatic segment 7. We proceed with Y90 mapping. This demonstrates the right hepatic lobe, which right hepatic artery selected. And then trying to get into subselective imaging, trying to target that and isolate that lesion within the posterior right upper hepatic lobe. Obviously, sometimes very difficult, hypovascular, difficult to determine. Trying to get it as sparing as possible with this treatment, considering the patient's only 58 years old and only solitary metastases. So what do? We bring in, slide in the CT machine. Literally takes me 2 minutes to do that. Slide out the table and try to get some amazing intraoperative CT images. And that's what we have right here. This is injection in showing good opacification enhancement of the region intended to be embolized and very selective. Literally took me 5 minutes to do. That's a question that's often asked. How long does it take to do this, to go from CT to angio? Literally takes 5 minutes. The other question I get is, how long does it take staff to learn it? I would say fairly quickly. Within a couple of months, I'd say we were very efficient at it. And this is the post-treatment CT and PET scan 3 months out, demonstrating resolved hypermetabolic activity within that posterior right hepatic lobe, expected post-radiation changes, very selective, very good outcome in this case. Let's jump into case number 2. We have a 66-year-old male with a history of hypertension, CHF, PVD, and BPH. Hospitalized for recurrent UTIs, subsequent Foley catheter placement, has an international prostate symptom score, IPSS, of 20, has a Qmax of less than 8 milliliters per second, prostate volume greater than 50 grams. Patient had a very large prostate gland, negative PSA. IR consulted by urology to see if there's any treatment options for his BPH. Deemed the patient a good candidate for prostate artery embolization, so we go ahead and schedule him in our hybrid room. This is the pre-procedure CT demonstrating markedly enlarged prostate gland. Had a good idea what the vessels had looked like, and we get him set up in our angio suite here. And so we get to work and we select the left prostatic artery, and we have questions. Is there any extra prosthetic extension? Would there be non-target embolization? You see a branch extending inferiorly. Was that going to the inferior rectal? Do a quick CT, literally bring it in. Takes about a minute or two to do that. Take an intraoperative CT, which you can see is amazing. You see that nice enhancement of the left half of the prostate gland with no extra prosthetic extension. That's the Foley catheter in place. And then we go ahead and embolize with confidence and without any questions. And we move on to the right side and get into the right prostatic artery. Switch over to CT, see complete enhancement of the right prostate lobe. And we also see no extra prosthetic extension and embolize without complication, without any hesitation. The Alphenix 1 gets approximately 16 centimeters of coverage on one spin, so you get very minimal artifact, especially with case 1 when you're talking about respiratory motion artifact. So I really just wanted to get into how this solves our workflow issues. Really what it gives me is the confidence and the ability to go into any case knowing that I can ultimately get it completed without any issues. For example, I had a case about 2-3 weeks ago, a 40-year-old, portal hypertension, gastric varices, hemorrhagic shock, Not a candidate for TIPS procedure, had a previous cartal for a gastric barracks, needing additional embolization via a transhepatic approach, knowing that I had ultrasound, fluoroscopy, and CT at my disposal to get into the vessel that I needed to get into the portal system. It gives you complete confidence, especially when you're talking about like 1 o'clock at night and you want to get out without any issues. Or for example, when I had a kyphoplasty just a week or two ago, severely osteopenic patient, multiple previous kyphoplasties, T2 acute compression fracture, bring him in with anesthesia, do angiographically or fluoroscopically, can't make out the pedicles at all. So osteopenic, switch over to CT, get my access, switch right back over to angio, get the cement in without any issues. Or we had another case, metastatic cholangiocarcinoma, previous CBD stenting, comes into the hospital with infection and has a progression of disease with an isolated duct within the superior right hepatic lobe, single duct, infected duct, needed to be targeted, can't see with the ultrasound, can't get to it fluoroscopically, switch over to CT, get your access, and then come right back into angiography and get that sent in without any complication. Or having the confidence going into a simple case like a lung biopsy, develop a tension pneumothorax, boom, switch right over to fluoro, get my chest tube in without any complication. Or if you had a hemothorax that would develop, and switching right over to fluoro and getting that done without any hesitation. Ultimately, you don't have to worry about where your cases get scheduled. You can bring it into that room, whether you're using CT, ultrasound, you know that you'll be able to get it done. The best part is not having to leave the department for it. It's really solved a lot of our institutions' workflow issues in regards to us having to go to diagnostic CT scanner and then competing with the ER in our outpatients and working with staff, non-interventional staff. Now it's just all in-house, and has been amazing innovations in workflow in regards to detecting submassive pulmonary embolism and bringing them straight from the emergency department into our lab, doing a quick CTA, and then confirming and then switching right over for catheter-directed thrombolysis. Cases get done more effectively, more efficiently. You know, you can get any case done, whether it's a tough access on a gastrostomy tube or placement of a peritoneal dialysis catheter where you may need CT. There's just no hesitation. I'm very excited about future innovation. I don't see us practicing any other way, actually. It's very difficult now, once you get used to it, to see yourself practicing without it. I'm excited to see what types of innovation happens and what the rest of the interventional radiology community can do with this equipment. Take care.